Thank you. These are my declaration of interest. So the topic that I will have to discuss with you today is a review on how we can use liquid biopsy concept in the management of colorectal cancer. We know that blood-based biomarkers in cancer are becoming increasingly important, and actually we can measure with more and more sensitivity and specificity, not only DNA, but also RNA, microRNA, and obviously protein. And we must remember the sources are very different, from cell-free circulating nucleic acid to circulating tumor cells, from exosomes, and even from platelets. There are a few important challenges that we are still to solve for the analysis of circulating free DNA. First of all, the absolute levels are very low, although with the more recent techniques, especially when we use multi-gene assessment by next-generation sequencing techniques, even a few nanograms per ml of plasma can be detectable and measured. And an important issue is that circulating cell-free DNA is a mixture of tumor-derived DNA and normal DNA deriving from large varieties of normal dividing cells. And therefore, the circulating tumor DNA is only a fraction that can go from as low as less than 0.1% to as high as 50% of what is circulating as free DNA in the plasma. And an important issue is that obviously the higher tumor burden, the higher is the possibility that cell-free DNA is shed by cancer cells and could be found in the plasma, and therefore is higher the chance of finding mutations or alterations in advanced or metastatic patients. And usually these are short sequences, highly fragmented, and the range is relatively small in size, from 50 to 200 base pair, and the half-life is obviously relatively short. So basically, 4 potential applications can be seen in management of colorectal cancer, from early stage of disease, even early diagnosis before cancer is known, to the detection of minimal residual disease. And this will be mostly, I guess, the topic of the next presentation. And I will focus more on molecular profiling for the identification of prognostic, but more importantly, predictive markers for precision medicine approach of therapy, and obviously in a dynamic sequential timing monitoring response to therapy to study clonal evolution of a tumor. In the time of detection of early disease recurrence, there is very interesting data that show clearly that in stage 2 colon cancer patients that underwent only surgery, the presence of circulating tumor DNA predict recurrence, and the same is in terms of adjuvant chemotherapy in those patients with high-risk stage 2 disease that underwent adjuvant chemotherapy. And this precedes radiological progression and rise in CA level. In terms of molecular profiling for the identification of the disease, now we have more and more evidence that what we found in the tissue is more or less found also in the plasma in most patients, in a very similar way in terms of sensitivity and specificity. These are the first data that came from a series of retrospective analyses that were using mostly the Sysmex beaming assay, but also with more recent techniques and other vendors, it's possible to find similar results. Basically, the first study by Schmigel was basically done in Germany, whereas the other 2 studies published last year in Annals of Oncology was first author Salvidal and Grasselli, come mostly from a series of patients from 3 institutions here in Barcelona, from Ramon Salazar, Clar Montagut, and obviously Josep Tabernero at Vio. And without entering in the details, we can say that when you use beaming technology in tissue and in plasma, there is a very high concordant level in defining if a tumor is RAS wild type or RAS mutant. And so clearly this shows that it is feasible and is possible to measure with almost the same accuracy by beaming technology the presence of mutation. And actually, if you just see in these retrospective cohorts that are in the Grasselli paper of treatment with anti-GFR plus monoclonal antibodies plus irinotecan in a second or third line setting, these patients can be equally evaluated in terms of disease-free survival, either if we use standard of care tumor assessment or cDNA evaluation of RAS mutation prior anti-GFR therapy. And so there is at least a very relevant concordance. Within our trial that we did a long time ago, the so-called CAPRI GOIM trial, we tried to see if this could be reproduced. And in the trial, we had originally 340 RAS exon wild type, KRAS exon 2 wild type patients, and out of these 182 patients were tested with a simplified NGS analysis on the tissue, on the primary tissue, and half of these patients were also having a baseline plasma sample that was available for testing. In our analysis, most of the cases were concordant in terms of having either ORAS wild-type tumor or any mutation in K or NRAS genes, but 10 discordant cases were with plasma mutated and tissue wild type, and vice versa. 10 were in mutation in the tissue, a wild type for the plasma. So the concordance here was much lower, although you have to keep in mind that these were archival samples that were taken and preserved as plasma few years before the analysis. Actually, if we compare in terms of predictions of PFS and overall survival, the baseline plasma versus the tissue determination of KRAS and NRAS mutation status, this correlates very well. And so patients treated with FOLFIRI plus cetuximab with the RAS wild-type tumor as detected by tissue were with much longer PFS. In this case, the median progression-free survival exceeded 12 months, and conversely with much higher overall survival, about 3 years, and the same with very similar figures could be seen with the liquid biopsy testing. Interestingly was to analyze which were the differences between discordant cases in terms of, for example, mutant in the tissue and the plasma in the wild-type cases. As you remember, these were 10 patients, and there were some common characteristics. For example, 7 out of these patients had a recurrence of the disease after the surgical resection of the primary. So the primary was where the mutation was. And the recurrence in most of these cases, at least in half of them, occurred relatively later, after 1 year, and most of the lesions were outside liver, where usually there is much higher concordance. And in any case, these 10 patients had an higher survival. And so a negative liquid biopsy may suggest in this case a much lower tumor burden and a better outcome. But on the other side, patients whose tumors were mutant in plasma, 9 out of them were really mutant, and so basically was, in most cases, the plasma determination was much more sensitive than determination in the tissue, but in any case, this underlines the tumor heterogeneity that can be found when we measure in the plasma. Obviously, one of the assumption is that we are collecting anything coming from any tumor site, whereas when we are testing one tissue, we are testing just one tissue. And therefore, an important aspect is how we can monitor response to therapy in order to take into account clonal evolution. And we know that, for example, even after chemotherapy, circulating tumor DNA can change, and usually if it changes, at least there is some evidence that if it changes early after starting therapy, in this case chemotherapy, this could be associated with a better response and a better progression-free survival. In terms of what is the evolution of the appearance of mutations in patients treated with anti-GFR therapy and then recurring or progressing, obviously we now have a relatively well-defined landscape of gene mutations that could be responsible with a very high difference in terms of percentage and also very high difference in terms of clonality, because we have to keep in mind that maybe the highest clonality is still in the mutation of KRAS and NRAS gene. And therefore, even in terms of occurrence of mutations through and during treatment, there is an important subclonality. And as usual, we can think about being either de novo mutations or the selection of relatively small groups of cells. There were very small number of cells that were sorted out by a selection were killing the sensitive cells and favoring now an emerging group of mutated clones. And so basically, as was already pointed out by several reviews articles, in this case, liquid biopsy is the only simple tool that we could have in our hands as medical oncologists to understand in a single patient temporal spatial heterogeneity in cancer progression. But what was really interesting was this study published by the group of Alberto Bardelli in Turin now several years ago, that for the first time clearly showed that occurrence of RAS mutations were a key determinant for occurrence of resistance to treatment with anti-GFR monoclonal antibodies such as cetuximab or panitumumab. And Alberto and his group was also able to find that in some cases other mutations that were different from the classical mutations that are the ones that we find more in the tumor before treatment with anti-GFR antibodies could be found. And these mutations, we know now, have a very relevant temporal evolution. We know, for example, that the longer patients are not treated with anti-GFR, the higher is the chance some of these mutations disappear. But a lot of different studies, mostly by series or retrospective studies, have been showing with different techniques that the most common mutations that are linked to acquired resistance to anti-GFR treatment in metastatic colorectal cancer patients still belong to the RAS family of genes. To make things more understandable in a prospective way, there was this study. It is a small prospective liquid biopsy monitoring study done by Mani Hidalgo and colleagues here in Spain that was following 25 patients treated with FOLFIRI plus cetuximab in first line by consecutive liquid biopsy determination of the key genes for the pathway, and so the KRAS and RAS, PI3K and ACA and BRAF gene. And clearly, as you can see in this panel, patients have never developed mutations in the pathway where the patients are having the best treatment advantage. And you can see the patients with the continued circulating tumor DNA in the wild type status were those patients with having a better progression-free survival that translated in a much better survival. And so although this is a small single-arm series, this is very relevant for the concept that we were discussing. And again, the evolution of mutations post-treatment is quite remarkably different, not only in terms of genes, but also in terms of percentage of clones that are emerging. A clear evidence of this came with this study. I'm not entering the details of the study that Clara and Guilherme published earlier this year in JAMA Oncology, where the efficacy of a doublet of monoclonal antibodies to the EGFR, the so-called CMO4, was tested in patients with the refractory treatment to anti-GFR therapy. And molecular selection was possible because in this patient, a basal Gardand plasma assessment by NGS was done on 70 genes in terms of mutation, amplification, and deletions. And the interesting aspect of the trial in this part of heterogeneity was that the basal liquid biopsy assessment of genes in these patients following resistance to anti-GFR treatment and before CMO4 treatment was that a lot of genes were mutated. Clearly, clonality was very different, and APC and TP53 genes were those that were basically mutated in most of the cells and were really clonal since the origin. And there was a hierarchy in terms of clonality. For example, KRAS was the first of these genes with higher clonality, and if we set at 20% in a very arbitrary way of mutant allele frequency, the possibility it is a clonal tumor, this applies only for KRAS and much less for NRAS, BRAF, V600E, and even for the emerging extracellular domain mutation for the EGFR. And if you see in the panel C, without reading, because it's impossible to read, you will see individual patients in which there is a number of genetic changes that involve a lot of genes. In most of these genes, these are subclonal. How this translates in efficacy or potential predictivity to response to anti-EGFR remains to be determined, especially for the role of EGFR extracellular domain mutations, because these antibodies were thought to be developed to work also in these mutants that usually occur in 30 to 50% of cases after prolonged cetuximab or panitumumab exposure. But to make things more complex, in this randomized phase 2 trial, the appropriate dose of CYMO4 was more effective than the standard chemotherapy approach of choice, only in those patients with what we called triple negative metastatic colorectal cancers that were RAS, RAF, and cellular EGFR domain negative. This telling you that the situation is more complex than we can think, even when we monitor patients in metastatic disease. So in conclusion, we need highly sensitive methods for detecting biomarkers, especially if they are of nucleic acid source in the circulating free DNA, especially if you want to look at circulating tumor-derived DNA. And the next generation sequencing-based techniques are maybe the best comprehensive molecular portrait for evaluating the tumor in the plasma. Therefore, I strongly believe that liquid biopsy will become more and more relevant as a practical tool that we as medical oncologists will have in daily practice, at least for the treatment of metastatic colorectal cancer, but I will say that at least for other solid tumors such as lung cancer or, for example, metastatic melanoma. And we need to learn more and more from prospective trials what means the high level of tumor heterogeneity that can be recapitulated in the liquid biopsy readout, because clearly the more we learn about subclonality, the more we shift from the idea that all cancer cells are equal and then they are different. And so a very important aspect, if we don't want to translate the concept of liquid biopsy to clinical practice, is the quality of liquid biopsy testing with an adequate monitored program of external quality assessment programs. And this has been very relevant when we started with immunohistochemistry with EGFR, for example, or for then for the assessment of mutations of KRAS and then NRAS and BRAF. And this becomes even more relevant when we do NGS in the plasma. Thank you very much.